Oh, hey, look, we're here for another epidose about coding. So tonight's topic is one where you will hear and see a lot of silence coming out of my mouth. Yes, so breathe that in and savor the moments of John's silence. Tonight it's obstetrics and gynecology coding, OBGYN for short. So yeah, well, as a dude, I know nothing about it. Never will know anything about it and will never speak from experience. So, as a way for me to compensate for my relative silence, I'm going to let the true experts answer my rambling and occasionally very awkward questions today. So, tonight we have three panelists. We have Kat Pahira Aiken, who will be discussing her daily routine as a production coder and OBGYN honor at Capital Health. She is also an SME for the AAPC on OBGYN coding, obstetrics and gynecology. We have Barbara Shaw from Duke University Health System, and she is their compliance specialist. She'll be discussing her role in obstetrics as a compliance specialist and longtime coder and SME at the AAPC. And lastly, we have Melissa Kirshner of Olympia Medical LLC, who is a former chairperson of the AAPC Documentation Advisory Committee, and she'll be discussing OBGYN from the perspective of practice administrator and a person knowledgeable in team building of OBGYN coders. And I'm just going to sit back here and look on approvingly. So let's get started. So, Kat and Barbara, let's break down what obstetrics and gynecology and coding entails. And if it helps, just pretend I know nothing about this. What are the common treatments or common conditions treated? And what are the common services performed? And whoever wants to go first.
Okay, we're all quiet.
So basically, I mean, it provides, primary care as far as rendering those comprehensive annual exams, well-woman exams, to procreative management, patients that might have infertility concerns and that sort of thing, in-office care to invasive surgery, and then, of course, obstetrics. We can manage normal pregnancies. And if you have a practice that co-manages with maternal fetal medicine for high-risk obstetrics or even urogynecology, I mean, it just goes on.
It's all issues of women's female pelvic health. Covers anything and everything from having a baby in the beginning to end of life, where you may have issues, whether it's hysterectomy issues or bleeding issues. I mean, it covers the whole gambit of all of your female services.
Melissa, you want to weigh in on anything that as well, or did they kind of?
Yeah, I think the only other thing I was going to say is that a lot of our female patients use their OBGYN as their primary care provider. So they do end up taking care of a lot of other issues just as the first source of services for a lot of our female patient population.
All right. So another odd question, and I don't know the answer to this because I don't know the answer to this, but do any OBGYN coders or OBGYN providers, did they specialize into like niche field or kind of like a subspecialty of OBGYN? I know it's a hyphenated category, obstetrics and gynecology, but do you have people that only do one thing or only the other?
Yes,
sure.
They do
We've
it all.
We've got a lot of providers who can do everything, but we've got a lot of providers who will specialize in urogynecology. They've got specialties who just do infertility related services. I'm sorry, Kat, I think I cut you off.
No, I was going to say that as well. You also have your gynecologist oncologists for all of your female cancer issues as well. Some of them will specialize just in that aspect of it as well. Just cancer related issues, tubes, ovaries, uterus, etc.
Barbara, you want to weigh in on anything that you've seen that kind of falls within the scope of OBGYN that maybe like crossing the boundaries into other categories or?
No, just, I mean, I can only echo, what the other two ladies said, in that, the subspecialties typically are urogynecology, co-managing high-risk obstetrics with maternal fetal medicine. And that's pretty much about it.
Okay. So in regards to like urogynecology, what are some of the things that they would treat? Because that sounds like a very kind of specific thing. Like what would be like, some of the conditions, some of the treatments they offer? Like would these be like inpatient, outpatient, or diagnostic testing? But what can be done?
Well, you could have a patient that comes in, say they have an issue with postmenopausal bleeding, they do an endometrial biopsy, and it comes back with endometrial hyperplasia, or it could be consistent with the neoplasm. And at that point in time, if you just have a gynecologist in the practice and you do not have a gynecologist oncologist, then you would refer the patient to the GYN oncologist, to manage that condition. So that way, that surgical procedure to manage that condition can be done if surgery is recommended and the patient accepts it. That's one example.
A lot of gynecologists will specialize in some of the urological conditions because during pregnancy, it can put some stress on the bladder and push the bladder out of normal alignment, which ends up causing a lot of incontinence issues. So a lot of OBGYNs or GYNs who specialize in urology will do things like incontinence testing in the office. They do a lot of incontinence-related surgeries to sling the bladder, move the bladder back up into proper alignment.
How about you, Kat? Anything that you've seen in the urogynecology field that you wanted to talk about?
Sometimes it could even be as basic as that recurrent UTI. Whether it's that pregnant patient after delivery that's having issues, or it can even be an older patient that is having the incontinence issues with that recurrent UTI because of those issues. It really varies on who your patient is and where they are in their life cycle of how detailed it's going to be. It can be everything from that new mom to an older senior patient. With that need for specialty, especially with urogynecology.
Okay. Now, this is a little off topic, but I know we mentioned earlier that I've heard earlier that a lot of times OBGYNs can be your primary care. But is there any kind of other kind of crossover benefit to having both a primary care and an OBGYN provider? Because I know Medicare allows for like an annual wellness as well as an annual pelvic exam. Do you ever find that sometimes like kind of conflicts, or is there any issues with how people code that?
Mm-hmm. Sometimes you may be more comfortable with your GYN provider, especially if you're having endocrine issues. If you're having, TSH issues, thyroid issues, sometimes that's all related with other GYN issues, especially if you have Hashimoto's syndrome with that. Sometimes they're intertwined with your PCP and your GYN. And I think a lot of the times it could be comfortability as well. You usually have a pretty close rapport with your GYN just because of the nature of the visit and everything. Sometimes your PCP may handle more of your, I don't want to call them basic chronic issues, but just chronic issues that you may have, whether it's hypertension or diabetes or things that may not cross into your GYN realm. I think more of your thyroid issues, TSH levels, more endocrine crosses over with your GYN than average PCP visit that's doing like cardiac and lost my train of thought. the cardiac hypertension, diabetes management that way.
We do see, at least with some of the insurance carriers here who I deal with on a regular basis, we do see that they allow the OBGYN to really function as that patient's full-on PCP and expect that they are managing the hypertension and ordering the colonoscopies and things like that because of the relationship with the patient. So they do allow it. Now, how many of them do it is really anyone's guess. But OBGYN is kind of a unique specialty because if we think about pediatrics, it's birth to age maybe 21, but OBGYN can start seeing that patient as early as their first menstrual period in some cases, and they'll continue with them right up until death. I mean, they are with that patient for the long haul. So they're with that patient for every part of their life. And they develop a very close relationship with their patient. It's a very unique specialty, in my opinion.
Mm.
All right, so let's get into anatomy, and we can talk about anatomy. And when I say we, I mean you three. So what are the biggest issues with anatomy in regards to OBGYN and how they impact coding, and what should a coder learn before they want to start coding for obstetrics and gynecology? Like, what do they need to know anatomy wise and coding wise?
Well, I think for any specialty, well, I mean, depending on what your job is, but understanding the anatomy that's pertinent to that specialty is important. So for instance, if you are the person that codes or audits, say, surgery, and then there's different approaches to different types of procedures, you'll know, if this surgeon is a vaginal surgeon as opposed to, an abdominal, and knowing the approach of whatever the procedure is. It's kind of like a parallel would be interventional radiology and understanding all that heart anatomy and all that stuff that you know so well, John. And the same thing, different surgeries can be done less invasively, like in a laparoscopic approach as opposed to an abdominal approach. And there's great resources that can be helpful that, any coder auditor can learn for this specialty.
I think it's also key to partner with your providers, because if you are new to OBGYN coding, knowing not only where everything sits and how it relates, but sometimes you'll see them call out, especially if they're doing that sling or they're doing that hysterectomy, if they're going to reattach ligaments to other portions, especially in the world of gynecology, oncology. Sometimes it's pretty amazing where they're going to reattach something after they take diseased tissue out. They truly have a knack and a skill and a rhyme and reason of how and why they do things. So just to have that open rapport with your surgeon and not being afraid to ask of, what does that mean? You attach this higher. What does that entail? Is that something that's more work related? Is that something where you're possibly going to add a modifier to support it? Or is that part of the procedure? So just to have that open rapport with your provider and ask those questions of, what does that mean? Where does that go? What did you do? And then to have the rapport with them as well as explain to me how this works.
You'd be asking a lot of those questions. What is that? What does that mean? Where does that go? Those were the exact order of questions I would be asking, because I would be an awful coder in this field. I would get nothing.
I think that in any field, though, any coder really has to be able to sort of set their ego aside and be able to ask the provider, explain this to me, teach me. Providers love to teach. Can you teach me what this is?
They do.
You explain this to me.
Mm-hmm.
You're not going to get them to stop talking. in some cases, but that's good because that makes me a better coder.
Exactly. There's just so many questions you can ask where they're going to give you much more detail than you can even sometimes understand at a time. But that's always helpful in the future, especially when you say, explain to me how this works, or tell me, why this took so much more time. Um, you know, everybody knows that lysis of adhesions is bundled into your service, but to truly know when it's appropriate to add that modifier for increased work, if that patient has had multiple intra-abdominal surgeries and if it took them 2 hours to clean out adhesions to get to where they have to go, that's a different story than just 15 minutes of cleaning out adhesions. Being able to ask and explain, tell me why. I think very key with your providers, getting that story about that patient behind and having them incorporate that into their documentation style as well. If you truly do have that unique case of, it took so much extra time to clear out those adhesions to get to what they needed to do.
Right.
Mm.
That's so true, because you'll have that physician that will come in and they'll say, oh, okay, I did a lysis of adhesions, a right salpingo oophorectomy, and they'll say, and oh my gosh, the pelvis was just rock hard solid. I was standing for 4 hours. Oh my gosh, you need to tell that insurance X, Y, and Z. Well, the whole thing is we need to make sure that operative report encompasses that, because you're going to put that modifier. And another good thing that helps is having a cut to close time, when typically when you do this procedure, it takes this amount of time, but what explains the detail of that significant procedure and why it took so much longer, as it's documented within the operative report, and the cut to close time is significant.
Okay. That's a very well-rounded answer on that. There's a lot of anatomical information that we have to relay in our obnos. So let's talk about what your daily life is like when it comes to coding. What is your routine, and what are some things that may throw you off your game when you are coding? What's your workflow like when you're coding day to day? So people that are outside that want to learn OBGYN kind of know what to expect.
It's really going to depend upon your practice and what they do. I mean, the providers that I work with do everything from deliveries to hysterectomies to pelvic health. I mean, they do the whole gambit of services. So when you see those charges come in, I'm looking at everything from OB triage visits to that delivery, to that C-section delivery, to a hysterectomy, to sterilization, removal of tubes and ovaries. I mean, you never, the only way you're going to have a heads up of what to expect is to look at the surgical schedule for your group. So, I mean, unless you know what they're doing, I mean, and know what patient, an idea of what surgeries are booked, it depends upon your practice and what they're doing. I mean, you could see this morning myself, I had everything from deliveries to hysterectomies. So from that 16-year-old patient having a baby to a senior patient having her uterus removed. So you have to be able to switch and change gears as you're working through those daily charges. I mean, you're never going to know unless you pre-look at their surgery schedule of what's going to come through.
Yeah, and it's not just the surgery schedule. A lot of times it's all the stuff that they do in the office too, because OBGYN in particular is not just office visits. There are a lot of procedures that they do in office that we end up having to code as well.
Especially unexpected. I mean, it's not uncommon for a patient to come in for their annual visit. They're having a problem at the same time, and the provider decides it's necessary to do a biopsy at the same visit. So, I mean, you know, again, unless your patient tells you when they're booking their appointment, oh, by the way, I'm having this problem as well, you may not know. Or if that same patient comes in for their annual visit and they're ready to have a baby, you could be doing an IUD removal at the same time as their annual visit. So you have to be prepared for the, oh, by the way, is there another problem truly being addressed? And since you have that rapport with your GYN as one of your primary physicians, that, oh, by the way, is kind of normal. You know, it's like walking into the PCP of, yeah, I have a cold today, but yeah, I have no more medicine for this. You know, GYN is kind of the same thing, but it's centric to female issues and problems sometimes. So, you
That they
know,
don't want to tell the front desk about.
exactly.
They don't want to say anything until they're in the room with the doctor.
They will not tell. It's frequent to see in the chart note or whoever's scheduling that appointment, it's a GYN follow-up, and then the provider has some kind of crazy issue. Oh, by the way, or just this morning as well, I was talking with another coder of, they had an annual visit, and can I do my new pregnancy visit at the same time? They're like, what? You're pregnant? Like, maybe you should have told me that when you booked your appointment for your annual, that, you know, P.S. by the way, I'm pregnant, surprise. You know, sometimes they just want to talk to their person. And they're definitely may not tell the nurse or whoever's rooming them in the room of that issue as well until their doctor comes in. And don't be surprised if that provider's out delivering a baby and somebody else is going to cover them, that patient goes, oh, I don't want to see you. Or if they're typically see a woman provider and a man comes in to cover, oh, no, I got to get dressed. Like, I'm not going to see you. That happens as well. You know, women can be very particular about their person.
How about you, Barbara? Anything you want to weigh in on that?
No, I totally agree with what Kat said. A lot of times the patients are, I guess you could say, under the witness protection program where they do not want to say anything and they have this significant problem. And then they come in and, you know, they've got this major thing. And of course, the doctor's trying to take care of them and then it throws the schedule off. So that happens quite a bit. Or you have that obstetrical patient and you know, you need to do an ultrasound, you know, add that into the schedule. And, you know, well, that can happen to one patient. It could happen to 10 in the course of the day. And that significantly changes things. The ultrasound tech is busy. The physician is busy. It can perpetual just be this evolving thing that, you know, one significant patient problem after the other.
All right. Well, let's see if we can switch gears and talk about the global period. And I know this is something that's always confused me. And Kat, I know personally, has gone over this with me like 17 times. The global period, prenatal visits. Like, I can't get a grasp on how this works. Like, something like you get, 18 prenatal visits and 6 postnatal visits. How does this work? Because I'm used to counting days. Okay, we have 90 days of care. But it's not always the same way with OBGYN because you have a different classification of they have their own I understand that Medicare defines what the global period is by each procedure having an XXX indicator, a YYY, ZZZ, and it helps determine what the global period is in relation to whatever. But I never got this. Someone to help me with this.
So maternity is a totally different animal because your patient is pregnant for 10 months. I know we all say 9 months, but it's really 10 months.
Mm-hmm.
All of those services that are provided to mom while she's pregnant are included in what the doctor is going to be paid for that antenatal care and that delivery. So it's typically around 13 visits is the standard OB package, plus delivery and then your postpartum care. And there are lots of different ways that we get the baby out. I mean, really it's two, but from a coding perspective, lots of different ways that it can happen. And pretty much everything that we do with the patient is going to be included in that global period, outside of maybe ultrasounds or complications that mom may be experiencing.
That's one of the things you have to definitely check the patient's insurance for.
Yep.
Sometimes they get so many ultrasounds that are bundled into their prenatal package. Sometimes after 3 ultrasounds, it's an extra expense to the patient. Doing that pre-work when that patient comes in for, hi, I'm pregnant, and you research all of that. Sometimes you need your nurse or whoever's doing that education for your patient is very clear with the mom of, you get so many ultrasounds that are included, and everything after that above and beyond may be an additional cost. Because it's not uncommon for, that new mom to come in and say, but I want an ultrasound, but we can't see anything yet, but I want an ultrasound anyhow. Or they come in, everybody's so excited they're pregnant, and they're like, I'm 5 weeks pregnant. And the doctor goes, that's great. I can't see anything for a couple more weeks. But what do you mean? Do an ultrasound. I took the test. The test says I'm pregnant. It tells me like right away. That's wonderful. But this baby, this new person, this, it needs some time to grow a bit and make it so we can see it. Sometimes there's just lack of understanding of, what do you mean you can't see anything? And you never want to freak out a new mom when you set up the ultrasound and it's this tiny little blip on the screen and they go, what do you mean? Where is it? Or how come it's, what their expectation is going to be versus what it is at that point, and everybody has this misconception of, oh my gosh, I'm pregnant, I can eat whatever I want. Well, that's great, but you have to also take into account of whatever you put on plus that baby could be a lot, and that may not always be the best for that person, and sometimes explaining, that's great, I know you're craving ice cream and chips, and that's what you can eat without throwing up, and I can't eat any of that, that's going to make me sick, but that may not always be the best thing for you, and then when you have to explain, sometimes the more weight you put on and the way that baby's coming out, it can make your delivery that much harder. And they, sometimes they give you that look sideways of, what are you talking about? Well, when you have so much baby and so much stuff trying to come out of a small spot, there's extra pressure sometimes, and sometimes new moms, you have to explain it, in detail of what to expect, and sometimes, I love how everybody does the shower and all this fun stuff, but sometimes people never tell you what truly happens when this baby is happening, or the kind of pain you may be in. Everybody's like, no drugs. I want this to be natural and everything else, until you're there praying to God of, make it stop. I don't want this to happen, and it's funny, ladies can sit back and go and laugh because they've either done it or they've experienced it, or they've heard their girlfriend, and their horror stories, or however it may be. It's kind of like the things they don't tell you when you buy a house, the things they don't tell you before you have the baby.
I remember
very important sometimes to get those details. In the
delivery room once about 20 years ago, where she reached up and grabbed her husband by the neck halfway through the delivery and said, if you ever touch me again, I'm going to kill you. I had to turn around and leave the delivery for a little while after that one, because I just it was like a TV show. It was like a movie scene.
Exactly. But you know what? It cracks me up even more for no matter how traumatic that delivery is, you seem to forget about that when you want your second baby or your third baby or, you know, whatever number baby that is, all of that craziness, you just forget. And until you're back in that moment and you're looking at your husband like, for real? Like, it's like, I'm doing this again for why? Like, you know, and then you'd have that new baby and it's like, oh, all right, whatever, you know, who cares? You know, it's all good. And even the recovery period of that, you know, sometimes they don't explain what's all going to be coming out of you after that baby comes out of you. You know, sometimes that, especially that new mom is like, I've never seen this before in my life. What is this coming out of me? You know, yeah, like I said, it's all those things people should have told you that they didn't, you know, the big secret shouldn't be such a big secret.
I would prefer the secret. Yeah. Couldn't done without that, to be honest. How about you, Barbara? Anything you want to weigh in on the global period? Because I have this really long roundabout question that just popped in my head a couple minutes ago, and I'm curious. But anything you want to add about the global period? The whole 10-month process?
Well, I mean, the big thing is when it comes to obstetrics, and then if you look, especially during the pandemic, there are a lot of us that are working remotely. You know, you might live in this state, but you might work for a company in a different state and all of that. So sometimes you have to pay attention to those things, because when it comes to obstetrics, you might have a payer that says, we want you to bill separately for all the antepartum care, all the pregnancy visits, and the bill separately for delivery. And so you have to follow those guidelines so you get paid when you send that claim out the first time. So there's those types of instructions. Another parallel within OBGYN practices is the same thing. If you have a patient that comes in for their pre-op visit and you want to bill for that Z code for a pre-op visit, you might have a payer that says, no, we do not want that Z code. We want the reason, the diagnosis of why this patient needs surgery. So there's understanding, you know, payer guidelines and that sort of thing. And Missy did a great presentation for my chapter, you know, talking about NCDs and LCDs. And, you know, when it comes to the middle revenue cycle, there's just so many details that are pertinent, you know, in any practice and in OBGYN. So definitely when it comes to obstetrics, understanding that is so important.
I think one of the big keys with obstetrics too is you're taking care of that patient for 9 to 10 months. Insurance changes, right? So you really have to be on top of what their insurance is and who you're billing and how you're billing them. And oh my gosh, we're in a new year now, and we did all of these things with them last year. OB is definitely a unique animal as far as that goes, because you're billing for things that are a year old. We started that service 10 months ago.
And that's my question. So one of the people on LinkedIn, Catherine Rose, asked it, and I was thinking the same question. Like, what happens, like, you're watching an ABC movie of the week, and, like, the baby gets delivered in the elevator by the guy driving the cab, all right? So the OBGYN has been treating this patient for, like, 6 months, right? They're racking up OB visits with the understanding they're going to build the global period for this surgery that they didn't do. So now what? Like, if their insurance company has, like, a 90-day timely filing fee, and you're already 3 months behind, like, what do you do? What happens if, like, you know, somebody else does that? It happens, like, they're not there for delivery, like, they have, like, an emergency in, like, the mall elevator, and or, you know, something like that. Like, how do you account for that? That's gonna keep me up at night.
That is very typical.
This is it's like being the guru of word problems. It's like that being analytical. They started their pregnancy here. They had this many visits. Okay, they had the baby in the parking lot, or, the physician didn't make the delivery. You just you have to be very aware of everything that went on with the course of that care, along with keeping up with the insurance changes. It's just a lot of details.
You definitely need to be detail oriented, and that provider will not get credit for that delivery if that baby is born in the parking lot outside of the hospital. They're going to get credit for all those prenatal and postnatal visits, but they're not going to get that delivery fee. Or as we sometimes see, if the nurse is in there with the patient and that doctor is held up with another patient, if that nurse delivers that baby, that provider's not getting that global delivery either, because that nurse is the one who delivered that baby. And sometimes that may be tough for your provider to swallow, especially since they've had this patient through their entire pregnancy, all what encompasses that pregnancy for that patient. That won't be a global service, unfortunately. It'll be their prenatals and postnatals.
Prenatals, postnatals, maybe delivery of a placenta, depending on when they get them to the hospital. But it happens where sometimes they just aren't there for the delivery.
And same thing too, you'll have that patient who is seeing a midwife, and they think they're going to deliver at home, until all of a sudden there's something unforeseeable comes up and they're rushed to the hospital because it's beyond the care of that midwife. They need a MDDO if that baby's breached and they need an emergency C-section, or the patient has uncontrollable bleeding or something. In the same respect, that provider can pick up that delivery of that unexpected baby, where a different facility altogether is going to get credit for all those prenatal and postnatal care out there. I mean, we see that happen as well, or patient delivers early and they're wherever out of state, come in, and when that baby's ready to come now, they're going to come wherever you are. You may not be home.
Now, do insurance companies kind of compensate for that? Like, if you're you weren't the one that actually delivered them as the MD or as a provider, do you lose out on all those prenatals if you don't bill in the right amount of time? Do you have to submit those all throughout the pregnancy, or do you submit them once at the end, with that as part of the delivery, or do you anticipate there is a possibility that we're not going to pay for any of these at all?
It is highly likely sometimes, if that patient has a 90-day billing period, especially if it's a Medicaid or Medicaid HMO that has strict filing guidelines. OB is all about being detailed in all aspects, whether it's your billing, your record keeping, everything. Timely is your best method to keep track of all of that, especially if you have an insurance with a small window and there's an insurance change midway through. You don't want to lose out on half of that prenatal period because you forgot there was an insurance change. That's a tough denial to swallow of timely for 4 months of care for that patient. OBGYN is all about being detailed in every aspect, is the best takeaway.
Absolutely.
Well, I'm sorry, go ahead, Melissa.
I was going to say, even tracking those patients, because you can have a patient who you started seeing and all of a sudden they're not coming to see you anymore. They didn't like you. They're changing doctors. somebody's got to be on top of the fact that that patient had 3 OB visits and then never showed back up again, because I've got services that I can bill out, assuming that I don't hit that timely filing. So it's a lot of record keeping and a lot of tracking and a lot of spreadsheets or tickler files or EMR flags, depending on the system that you're using in your office.
So
It could also be your patient. You know, sometimes, especially, I think we saw it the most with COVID, of patients didn't want to come into the doctor's office because the risk of getting COVID, and, you know, I'm pregnant, and, you know, I don't want to be exposed to anybody else. So sometimes you would see that gap in their care because they just didn't want to come in because of, you know, where COVID was at that time.
Right.
You know, so you'll see them for the first couple, they fall out for the next couple of months, and then they come back in, like, hi, I'm ready to deliver. Here we go. And you're like, where have you been? You haven't answered a phone call, an email, and anything. But detail. It's all about being detailed.
all right. So what are some other skills that you feel is necessary besides being detailed? Like, you have to have like an eye for anatomy. Are there a lot of reports? Like, I'm used to reading long op notes. Is that the same with an OB? Like, I can't imagine there's really a lot of like a detail with delivery, but I'm sure I'm wrong about this. 100% sure I'm wrong. Yeah.
Really depends on the specialty that your doctors are doing. If your doctor's doing a lot of urogynecology, those operative reports can be very long and very detailed. If they're doing a lot of straightforward deliveries. But it totally depends on the provider and what they're specializing in. But yeah, we get some really long operative reports. We can get some really long delivery reports because they ran into a complication.
So our 18-hour deliveries are really a thing. Like, I can see that as something that would like have like a 37-page op note. You know, hour 1, hour 2, hour 3. How long do they go? Like, what's the longest you've seen a person in labor? I mean, no HIPAA breaches. I'm just curious. Like, throw a number out there at me.
Care has definitely changed through the years. I can speak on behalf of my mother. I was one of those crazy deliveries that was over a day. I mean, back then they tried to stop her labor because I was too early. That's not necessarily the plan of care anymore. Fear of dating myself, I won't say the years, but you know, that was something that was common, you know, then. Now, if I see a patient labor more than, I'm going to say 12 to 18 hours, it's bizarre. They usually don't like to let their patients labor that long for fear of infection.
All right, so let's move on to coding expectations. So, like, I know a lot of people that may be interested in learning obstetrics. Like, there's a lot of expectations that you, as a person in your role, have met when you obtain that role. But what are some things that most employers look for when they like interview candidates for these kind of jobs? What are the must-haves for OBGYN candidates? You know, and you can even throw in that, you know, they're not men, because I've had that response as well. Like, I won't apply for any jobs because like, what's my chance of getting a job? Probably 0. Might even be less than 0. They might actually say, we're not hiring you for anything even outside because you tried. But
I don't know that it's anything different than what I look for in other specialties. I want someone who is detailed. I want someone who's confident. I want someone who's not afraid to ask questions and to be inquisitive. If you don't have the requisite experience coming in, are you willing to learn? Are you willing to put in the time?
Yeah.
Are you timid when we're sitting here having a conversation? Because if you're timid with me, how are you going to be with the physician? OB-GYN is one of those specialties. I mean, I've been doing this. This is my 39th year. I love it. And it's so rewarding. It's my favorite.
This is my 39th year too. That's so good. But I always, when I was a practice administrator for the OBGYN practices that I worked at, and if I was filling a clinical role or an administrative role or, front desk or what have you, and if I had someone that was interviewing for the job and they had great skill sets, they were going for a coder or someone doing charge entry, and they had that experience, but they did not have OBGYN experience. And I always told people, especially if they were new into the career, is, learn the specialty. You do it for a few years, learn everything about it, and then decide if you want to stay with it, and advance yourself, but definitely learn the specialty. And I think, like Missy said, learning is so important for any specialty. I mean, there's so much to learn about it. There's a lot, from the obstetrical side to the GYN side, just a lot. And I think that's pretty much for all of them. I mean, I know I've worked in different specialties too, but especially OBGYN.
No,
and then there's great resources we can use.
Yeah, I've learned a lot of different specialties, and I've learned by watching YouTube videos. I don't imagine that's the same kind of situation you would find in obstetrics. I'm not sure. Can you see like live deliveries on YouTube? Is there like ways that like you can get a feel for like, doing these procedures or doing hysterectomies? Like, can you? I'm just trying to think. Like,
you can YouTube it.
Yep.
Can you? I didn't know if there was some kind of like, if YouTube had any kind of like age restrictions on those kind of things, because I'm pretty sure that would be a lot of sensitive material in these videos that you might have to have that adult access for. I don't know. No, I'm just like, I've learned podcasts from watching YouTube videos, and that's a different situation. But like, I always throw it out there, watch YouTube videos. I don't know that I can do that for this specialty because of the sensitive nature.
I remember giving a chapter exam several years ago, and there was a Lamaze class happening in the room next to us. And we're in the middle of the exam, and it's nice and quiet in our room. And all of a sudden we hear a video start, and they say, "Your cervix and you." So there are definitely videos that apparently you can watch. Sorry.
There are definitely videos out there. The approach may be laparoscopic or abdominal. It may not always have so much detail where you can't see that procedure being done. But it all depends upon approach. You can see deliveries out there. How much you want to see, I guess, is going to be based upon you, but definitely get to know your procedures and what's entailed, and don't be afraid to ask your providers, because they'll tell you straight up of, sometimes as a new coder, if you question, how bad is a 4th degree laceration during delivery? When you talk shop amongst other OBGYN people, they'll go, "Oh, well, or they'll say something of end to end. And as a new coder, you may not truly understand what end to end means until someone explains it for real, of what that entails. So be wary of the questions you're asking and the answers you may get. Or of how much you may want to know. I mean, I could speak for myself. Before I was in OB, I was in peds, and I thought that was great. I'll be around kids. This is wonderful. And then I was like, oh no, this is not for me. Like, let's happen before, they become these balls of germs. There's got to be something better once you're in peds. So, I mean, it all depends upon your niche as well, of what you enjoy, what you find interesting, what's going to keep you motivated to learn.
But definitely don't be afraid to talk to your providers. If you can't talk to your providers, then there's a whole nother issue. But even I just had a case recently, and I was working on something for my day job, and I encountered something that I had never heard before. So I called my OB, said, it's not for me, but can you explain this to me? Because I'm like just researching and I don't know what this. Not only did she explain it, but then she started sending me articles about that particular topic. I mean, you have to have a really good relationship with them.
And nothing is ever too personal.
Not in this field.
No, it's completely open. They'll talk about anything and everything. And then, we even explore into circumcisions if your providers do circumcisions. So depending on where you live, your providers might do it. You hear those phone calls, if there's issues with that. So we hear it all.
Yeah, we didn't even talk about that, but that's definitely something that our OB doctors will do.
Absolutely.
Yep.
Oh,
That's a typical common procedure for them. Even if they everybody brings the baby in when you're coming postpartum, everybody wants to see that baby in the office. So it's typical that you're going to get new baby questions. Mom comes in for herself of, is this normal? Is this supposed to look like this? Kind of thing.
Did they give a book? Because I never got a book. They're supposed to give you like a handbook.
I think that comes under everything they're supposed to tell you, but we're going to keep you guessing for the next 20 years.
Yeah. Like things that my kid's going to talk about to her shrink when she's about my age. Like, he didn't read the book. All right. So I know we're getting close to the end here. We typically do about an hour, but when you're one to advance, like if you're in the field and you land the job in OBGYN, what are some of the ways that you can advance? Because it doesn't sound like it's a field where like you get hired, you're in the same role. It sounds like you can move around, you can cross train. What are some of the things that like they can do to like kind of cement themselves as like, like you guys experts? Like what can they do to get to that level or move from the entry level to the next level up?
Learn, educate themselves, get real comfortable with your specialty, get real comfortable with that anatomy and those surgical services. Don't be afraid to ask those questions. Make yourself stand out so that the providers are willing to take you on and give you more.
Right. And I mean, in the physician practices, there's a lot of different things you can do. A lot of times you'll have a coder that might say, okay, I want to get into the clinical realm of it. I want to be a nurse. I want to be an ultrasound tech. And sometimes you have a nurse that says, oh my gosh, I love coding or auditing. This is great. And then you might work at a university health system like myself. And so we do audits. I can do GYN oncology audits, OB audits, GYN, OB and GYN, and then I can do OBGYN edits and denials. And it's all about, we're in the middle of revenue cycle, getting those claims out correctly the first time, and then studying with edits and denials, what happened, let's make it better. So lots of great things to do.
I think being organized and staying on top of all of your different insurance carriers also makes you stand out, because if you can be the expert to answer those questions on what Blue Cross wants versus Cigna wants versus what app wants, you're the go-to person in the office.
Also keep in fact too, once you have that rapport with your providers, as you bring on new providers to your group, as I do with an auditor, we also do their E&M education. Sometimes it really helps to have a base of common problems. So when you're talking about levels of service and what kind of problem level they are and what the risk to the patient is and how important it is to document that patient's comorbidities, of getting all of that information from their head to the chart, also helps. I mean, because once you can talk about those conditions and you're comfortable with it, you can discuss with them, well, what else is going on with that patient? This patient isn't a typical otherwise healthy GYN patient, OB patient. They may be a diabetic. They may have hypertension. They may have had preeclampsia in a prior pregnancy. Being able to discuss the added documentation to support levels of service will help educate your providers as well. So, having that core knowledge of basic conditions, you can flip it and be an educator for them as well.
100%.
From the office standpoint, as well as quality documentation within their surgical reports. You can go back in and you can look at their surgical report and say, tell me about Sally. And they'll give you so much more information about Sally and her condition and what's going on with her than is ever on that piece of paper. Being able to turn that around and say, I think this is important. You should include this in your op report. To tell her full story of why you're doing what you're doing, especially if it's something that took extra time, or you're seeing that patient, for chronic problems in the GYN field. That problem may start out as a low-level problem, but as it progresses and that patient gets older, that's something that's going to become more and more severe. And that quality documentation to support that is going to help them with their office visits later on. So it's education not only for yourself, but it's what you can do for your providers as well.
All right. I just had a question come across the chat, and I blame the app I'm using because occasionally it does that. They come in delayed. But I'll put on the screen. Teresa Kelly asked, so some payers don't follow ICD-10 guidelines for pre-op clearance. And I think this goes back to the question that we asked about using the Z code versus using the O code.
Yes.
What are the rules about that?
Yeah, definitely. I mentioned that earlier. And when I do some OBGYN presentations, I'll talk about the pre-op visits, how some payers do not want that Z code for the pre-op visit as a primary diagnosis. They want the reason for the surgery. I think that's what Teresa was referring to. And again, it's echoing what Missy said, knowing those payer policies that are so important. And I think you find that within every specialty, understanding coding and documentation, but, getting into that revenue integrity part where it all meshes together. And as we have so many new positions, we've expanded greatly. And as artificial intelligence intelligence and our coding tools are coming out, we're layering what we know. You know, we're not just coders, we're not just billers, we're not documentation or clinical documentation specialists or whatever your title is. So it's learning everything as much as you can.
Yeah. Any last minute advice for any people that want to learn in this field? Things that we did not cover, things that are small little bits of information that could be crucial in saving their life.
The OBGYN Coding Companion is a great resource. Yeah, jump right in.
Mm. Yeah, don't be afraid.
Talk to the doctors, talk to the.
Absolutely.
You'll learn so much. You'll learn so much.
All right. Well, I do like to thank our 3 panelists for their very mind-blowing discussion, because again, there's a lot I still don't know and about this, but it's a great area to be in. There's a lot of OB/GYN practices throughout the nation, and they need coders too. So I'd like to thank Missy Kirshner. I'm going to put the information on for Missy if I can find the link. So Melissa Kirshner, again, she's director of Olympia Medical, and she's a former chairperson of the Coding Advisor Committee, and she offers a lot of information about OB/GYN. And then we have Barbara Shaw, who also gives a lot of presentations on OB/GYN, and you can reach out to her and ask questions. And then we have Kapahira Aiken, who joined us. She is an SME with the AAPC in regards to OB/GYN, so she handles a lot of those questions through the AAPC, and you might be seeing a lot more of her throughout the next couple of years. So again, I'd like to thank you guys for coming and listening to us today, and hopefully it wasn't too offensive this time. I'll try a little harder next time. But next week we have general surgery.
You did great.
Was it?
Good job, John. Good job.
I survived without being murdered. I'm like, this is a record. Although I'm pretty sure I did. There's somebody out there like, that guy, how? But next week, general surgery. So tune in. We have at least one scheduled panelist, but I'm still looking for a few more. So if there's anybody out there that would like to speak on their experiences in general surgery coding, I would love to speak to you. Reach out and have a good day, everyone.
Have a great night.
Have a good night.